So the learning objectives discuss the epidemiology, clinical presentation, and natural history, and describe the findings. And it's really a very clinical and a descriptive talk. There'll be some nice pictures. Some of them is quite fuzzy, so bear with me on that. But in general, I think the message here is we as cardiologists have played around with many different types of imaging modalities, and I think many of them are actually, we use it almost on a day-to-day basis, and it's very, very insightful as we continue to see many of these patients with these imaging modalities. So I have 3 questions here. The first question is, how often does EGPA involve the heart? I think Rula was very kind not to give away the answer, but and it's not the easiest to actually find that answer because of what I'm going to tell you next. I hope you don't answer number 4. Okay, all right, so there's a little spread. You're actually all somewhat correct because at least the literature is all over the place. In fact, when you actually have a prevalence range from 16 to 92, you always kind of laugh a little bit. But I think it's often quoted between 30 to 60%, which is what the majority of you actually answered. It accounts, unfortunately, about 50% of death, and I think that Kaplan-Meier curve that you saw just now really shows that the heart is important. I'm biased, I'm a cardiologist, but it's really mostly involved at the first few months of the diagnosis and in the active phase, and it persisted if you have actually persisted inflammatory response or downstream progression. As Rula said, it's more in anchor negative, just like other organ involvement. And it also relapses, although some of them could be asymptomatic. I'm going to actually talk a little bit about that in the subsequent slides. The pathophysiology is really unclear. In fact, it's not just EGPA. In fact, most of the hypereosinic syndromes, the heart seems to be preferentially involved. And there's a whole idea that teleologically, if eosinophils are actually developed along the path of trying to protect us from parasites or other organisms, I think one of the ideas or the concepts is that there may be some specific mechanism where there is some tropism to the heart. So even when we see tropical hypereosinophilic myocarditis or cardiomyopathy, we do see a very similar picture of a subendocardial involvement of fibrosis. And so the mechanism to which is still pretty unknown, although we do know that the presence of eosinophils in the heart is kind of one of the hallmarks. That also applies to kind of non-EGPA diseases, where sometimes we also see eosinophils there, and I'm going to talk about a little bit later. Of course, there is vasculitis-related ischemia and injury, but they are really small vessel diseases, so the epicardial vessels are actually not commonly involved. The second question, what is the least common clinical presentation of cardiac involvement? Fibrosis, regional wall motion abnormality, pulmonary edema by physical exam, or obstructive coronary artery disease? Okay. I just gave the answer away just now. So clearly, we actually, in fact, I was, while preparing this talk, I was looking at many of the cases that we've seen in our department, and the majority of them actually had relatively normal coronary anatomies when we do cardiac catheterization. Of course, many of them are also somewhat biased. They have kind of cardiac dysfunction when they come to see us. But clearly, the clinical presentation is myocarditis or perimyocarditis. Most of the time, they have injury in a format that is not very traditional. They have regional changes that potentially is not related to the anatomy of the coronary arteries. Pericarditis is quite common. In fact, one of the more common referrals for these type of syndromes actually come from our pericardial center, where they see a lot of so-called perimyocarditis when the troponins, the cardiac biomarkers get elevated, which is something I'm going to talk about too. Subendocardial fibrosis is actually somewhat common, as I said, in hypereosinophilic syndromes. Heart failure, interestingly, is not that common. Pulmonary edema and overt heart failure occurs kind of in the later stages. It's associated with the cardiac dysfunction. However, one of the things, unfortunately, some people do have cardiac thrombosis, especially the apical left ventricle, sometimes be related to low cardiac function or cardiac output, but most of the time due to the inflammatory and the regional wall motion abnormalities. Arrhythmia and sudden cardiac death is actually also present, and it does persist, interestingly, after transplant, at least in some case reports. Myocardial ischemia and regional wall motion abnormality can occur in tests when we actually do ischemic evaluations, but rarely we see overt epicardial coronary artery disease. So I mentioned about in the pathology, we certainly have been trying to find the eosinophils in the heart to justify the diagnosis, although it is just like any other inflammatory cardiomyopathies. It's actually very, very difficult. These inflammatory areas are usually very patchy, so just like sarcoidosis or any other kind of conditions, many of times we actually cannot catch these inflammatory cells. So unlike cardiac transplant, where it's usually quite diffuse, the yield of myocardial biopsy is actually quite low. And in addition, I think eosinophils can come and go actually quite often. So a case like this, usually most of the time we get it in autopsy cases. Certainly see clear eosinophil granules, but most of the time when we do biopsies with people with known diagnosis, we see fibrosis and myocyte necrosis with kind of a less prevalence of normal myocytes. So the early phase, we see extravasation of tissues, and then subsequently there are some replacement fibrosis and small to medium-sized vessel changes that our pathologists usually describe. Rula talked about the diagnostic criteria. I'm not going to go into it beyond by saying that many times we do see a lot of patients get evaluated, particularly the emergency room or when they're first diagnosed with signs and symptoms. Their cardiac biomarkers are usually increased. Most of them have detectable troponin levels, and some of them, if they have significant cardiac involvement, you can see their natriuretic peptide levels increase. How they track with disease status and progression is really not well described. There hasn't been case series or even studies on that because of the small number of cases, usually in small case series. We obviously try to see the degree of cardiac involvement. One thing to remember is most of the time when we do biopsies, we do it mainly in the right side of the heart. So we don't do arterial biopsy, so the involvement obviously had to involve the right side of the heart for us to actually have a good yield. Otherwise, obviously, but most of these hearts have a left-sided, predominantly left-side manifestation. So the definition of cardiac involvement varies widely. I think this Dutch series is one of the biggest series that actually look at it in multi-modality evaluation of cardiac involvement. And you can see that it's a diffuse potpourri number of abnormalities that we see in basically any forms of cardiac assessment. And that actually creates a very big problem because there's no single entity. Some people would have ST changes and some people have EKG changes. But interestingly, a lot of people with evidence of MRI involvement do not have significant changes or specific changes in EKGs. And so while it's a great screening tool, it's not a definitive tool. Echo remained the cornerstone, particularly with regional wall motion abnormalities and the presence of course, of thrombus, which is important for therapeutic indications. We have actually spent most of our efforts now using MRI because it allows better tissue characteristics, characterization, as well as fibrosis evaluation. And in late gadolinium enhancement, increased signals does occur during inflammatory response, both at the pericardium as well as the myocardium. So these are examples. For example, here you can see even some shadowing in the typical area at the apex area, which is where the majority of the scarring occurs. In echo, you actually do not see the scarring per se. You can only see the wall motion being slightly, altered or significantly altered. But in MRI, you can actually see the subendothelial lining many times actually involve intramural mural thrombus lining as well. Now, the cardiac imaging is actually quite good in looking at follow-up evaluation. This is a patient that had 2 months treatment of prednisone. And you can see that the majority of these patchy infiltrates that you see in the previous slides are actually gone. And there is still some mild pericardial effusion, and the thickening of the pericardium is actually diminished. And this actually allows us to gauge the efficiency of the therapy. So third question, cardiac involvement often resolves with remission. I would imagine clinical remission following immunosuppression therapy in asymptomatic patients with EGPA. It's true or false? You've got a 50-50 chance. Okay. So, in fact, it's there's a little difference in opinion. The bottom line is, I think we're going to hear a lot more about it later on. Interestingly, cardiac manifestation and changes are not thoroughly evaluated in the literature. Most of them are, case series, of course. But there's always been some controversy over kind of at least historical data saying that intensification is important, so cyclophosphamide you just heard. But interestingly, the latest guideline was very tepid in that recommendation. In fact, they say that cardiac involvement itself is not the ultimate indication, but they do say that it is helpful to intensify. So it's kind of, we still don't know exactly. Most of us are actually quite aggressive here when we actually see still persistent symptoms or dysfunction, we do that. But if the symptomatic remission does occur, I think the question that comes along is the cardiac manifestation still remain? Interestingly, we do started many of the standard heart failure medicines, just like in myocarditis. So ACE inhibitors, beta blockers, we also had mineralocorticoid receptor antagonists. You're talking about 3 or 4 different types of drugs within the first 3 months. Many of them may not have a lot of pressure. Many of them are symptomatic in terms of fatigue. In fact, we have to change many of the drugs all the time when we see the patients with our rheumatology colleagues here. It becomes a challenge because most of the heart failure drugs do not really have a tapering regimen. In fact, we tell our patients we take it forever, glad they're all generics and cheap and $10 a month, type. So what we are trying to figure out is what are the patients in myocarditis as well as in many of the rheumatologic conditions. Really it's a temporary change or whether we actually need long-term therapy. But most of them will actually maintain their therapy if tolerated. And interestingly, our experience, and at least the worldwide experience in transplant and advanced therapy is actually quite good in this condition. Patients do go through cardiac transplant without any big differences compared to other conditions. So that's a good news. In contrast, like lupus and some other more aggressive diseases have bigger challenges, but this actually, with the presence of ongoing immunosuppression, actually has pretty good outcomes or equivalent outcomes. So the asymptomatic EGPA cardiac involvement, which is the answer of that question, really there are 40% symptomatic patients with normal EKG has evidence of cardiac involvement. And in fact, in remission, a lot of patients continue to have persistent MRI-based changes that we actually observe. So that actually means that there is indolent disease that may not directly link to clinical symptoms of remission or relapse. And many times there are also things that particularly would be concerning, particularly with neurothrombus and also pericardial effusion and pulmonary hypertension. Now, usually imaging is the modality of choice, although there are wide variability still in their acquisitions and sensitivity specificity. And whether they're specific to EGPA is not really clear. In the same series in the Dutch group, they actually see very similar persistent cardiac involvement in the asymptomatic and asymptomatic patients on remission between GPA and EGPA. So I think at this point, we actually don't know. What we do know is that there is a subset of patients that had persistent cardiac involvement that maybe is the subset that we need to be much more aggressive to understand what they're doing. And one of the ways that we actually could look at it is kind of borrow from our sarcoidosis experience. It's really using PET scan to look at hyper-metabolizing evidence. Interestingly, in this cohort, only 10 patients, probably one of the only series in the literature where both PET scans and MRI are done, persistent late gadolinium-enhanced MRI in patients with remission, about one-fifth of patients do have PET evidence of very active inflammatory process ongoing. So whether that combination can actually allow us to even stratify patients that need more aggressive therapy should warrant further investigation. So in summary, I think cardiac involvement is common, and I think both rheumatology and cardiology colleagues, our cardiology colleagues also need to understand it's not just a standard or heart failure evaluation, but also maybe much more focus on immunologic interventions. EKG and cardiac imaging is key, although EKG in the long run also has quite nonspecific, and so is echo. So I think really had to focus on identifying what we're looking at, which is to really trying to detect the presence or absence of a cardiac involvement of EGPA or not. And indication for initiating intensification of immunosuppression therapy is likely important if the heart is involved. It is in one of the 5 scores, and also very clearly some subset would have persistent indolent inflammation, which at least in the myocarditis literature is one of the most significant adverse consequence, which matches the EGPA epidemiology. Thank you very much for your attention. Uh-oh.
My question is, the histology slide that you showed, the granulomas don't exist.
Yes.
I didn't see any granulomas.
Yes.
And the second thing is, why are eosinophils going to the heart?
Yeah, well, so the first question is why are no granulomas? Actually, we don't understand. I will be the first to say that I actually tried to answer that question by preparing this talk, and I think as I learned in medical school, if you have no idea and nobody knows idea, you can always say it's generally not well understood. And it's actually truth, it's generally not well understood. I think the question that comes along is whether it's the amount of granuloma that you see and whether it's persistent or not really classified one or the other. I'm actually, as I was sitting here, I was also wondered whether it's kind of a misclassification based on kind of a pathologic diagnosis, because we usually, when we see granuloma in the heart, we think of sarcoidosis. Okay, and we really don't know the spectrum, and just like Rula said, we probably need more biological classification than truly pathological. The biopsy itself is also very patchy, so we have not actually been able to clarify. In fact, many of our patients with non-ischemic cardiomyopathy that we thought have episodes of myocarditis, we see the same thing, very hypertrophy myocytes, replacement scarring, and kind of very nonspecific. The second thing is, why does it go to the heart? I said at the very beginning, there are teleologic reasons, but truthfully, the question is whether the eotaxin is actually much more related at the heart level. People postulated it, but we actually don't know.
Thank you so much. I have a question. So if we refer to you a patient who is EGPA and have a normal echo, would you go ahead and do further study with MRI? Do you recommend to have MRI, PET scanning, whether they have symptoms or they don't have symptoms?
Yeah, this is not just EGPA. This is almost on every non-ischemic cardiomyopathy that we deal with. It's always a debate that with more broader and better characterization of MRI and its consequences, particularly with late gadolinium enhancements, we have actually been doing more cardiac MRI, even on broad spectrum. The main reason is because the tissue characterization and this architecture does give us some insight. It's not just the cardiac function, yes, no. It's really how it's looked. For example, you saw the EGPA pictures. Many of them are actually in the subendothelial. It's really characteristics of eosinophilia-related cardiomyopathy. And so we actually routinely do that. The second thing is the characterization of the tissue is also much clearer as follow-up assessment. And that part, I think, is actually quite valuable because we are specifically looking at the organ level involvement and its resolution. If it is a scar, a replacement scar, we are starting to also learn that it is quite dynamic, but usually this resolution will not be that quick. So that is actually more indicative of an inflammatory process that is resolving.